Cardiovascular pathology, shock. All right, so let's first define shock. Shock is just the inability to correctly perfuse organs, okay, or adequately perfuse organs. All right, so we don't have enough oxygen and nutrients being delivered to the organs that are necessary, okay? That's all shock is. And there's different types of shock, which we'll get into shortly. But what I want you to know for all shocks is that we have severe hypotension with tachycardia, okay? So that's the first thing I want you to get out of the way, is that if you see a patient that has severe hypotension, for example, like 90/60, okay, start thinking about shock, 100/70, 100/60, with a heart rate of like something over 100, okay? Start thinking about shock because that's the first signs of shock that I always look for, the vitals, okay? Number two, something that we have to understand is that cardiac output is always opposite to our resistance, to our TPR, okay, to our SVR, okay? It's always opposite. And the reason behind that makes sense because when we have a drop in cardiac output, the organs want to be perfused correctly. So they're going to increase their resistance, just like when I put my thumb on a hose, right? I'm going to decrease the diameter there, but it increases the amount of perfusion that I'm going to be getting. Okay, so when I put my thumb on a hose, I'm decreasing the diameter of the hose, but it increases the amount of water, kind of the strength of the water that's coming. Okay, so those are the first two things you have to understand. Hypotension with tachycardia is the first sign, and then a drop in cardiac output with an increase in SVR, okay, or TPR, same thing. Okay, now let's talk about each specific one. So first, let's start off with hypovolemic shock. Hypovolemic shock is caused by anyone that's bleeding so much. So if you're hemorrhaging or you have dehydration or burns, okay, any type of loss of an extreme amount of fluids or blood, okay, with volume depletion, you're going to get hypovolemic shock. So we have essentially less blood in circulation. Since there's less blood in circulation, the first thing off rip that we're going to be thinking of is decreased cardiac output. Since we have decreased cardiac output, what are we going to see? Increased TPR, increased SVR, okay? Very easy, okay? Now, key concept. What about my PCWP? Well, PCWP, first off, is just the left atrial pressure, okay? So if we have less blood in circulation because we have hypovolemic shock, right? So there's less blood overall. If we have less blood, less fluids in circulation, that means that the amount of fluids pushing up against the left atrium is going to be decreased because there's less blood pushing up against it. Hence, I'm going to have a decrease in left atrial pressure, also known as PCWP. Okay? Very simple. So we have a drop in PCWP with hypovolemic shock. What about my central venous pressure? Well, central venous pressure, let's think about it through, right? We have a total loss of blood volume. And since we have a decrease in amount of blood that's circulating throughout my veins, then my central venous pressure is going to be decreased. Okay? Does that make sense? Lastly, the SVO2. So the systemic vascular oxygen, okay, venous oxygen. So the amount of venous oxygen is going to be decreased. And the reason behind that is because my organs aren't being perfused correctly. And since my organs aren't adequately perfused, they're going to take more oxygen out of the blood than they normally do. So the arteries are going to give them their normal oxygenated blood, and they're going to take out a lot more oxygen because they need it more because they're not being perfused correctly. And so that means that we're going to be measuring our venous O2. It's going to be a drop in venous O2 because, once again, I'm not getting my organs perfused well enough. So they're going to take as much O2 as they can out of the blood. Okay, so that's why we see a drop in venous O2. So overall, hypovolemic shock, it's secondary to either hemorrhage or dehydration or burns because we have complete volume depletion. And what we're going to see is a decrease in cardiac output with an increase in systemic vascular resistance. We're going to see a drop in PCWP, a drop in central venous pressure, and a drop in our venous O2, okay? You will see an increase in hematocrit and albumin as well as uric acid because you're losing plasma, you're losing volume. So everything that's located within the blood, okay, although nothing has been made, extra, but since you're losing volumes of blood, everything that has been present in the blood prior, it's just going to be increased in proportion because you've lost volume, okay? Next is cardiogenic shock. Cardiogenic shock means that there's something wrong with the pump, okay? So we can't pump correctly. And that's going to be caused by either like an MI, right, myocardial infarction, or heart failure, right, valvular dysfunction, arrhythmias, things like that. But we get left-sided heart failure, essentially, okay? That's one of the main causes for cardiogenic shock. So if we can't pump well enough, well, there you go. First thing you're going to see is decrease in cardiac output. And what did we say about cardiac output and systemic venous resistance? Is going to be, vascular resistance is going to be opposite. So SVR is going to be increased. Okay, so cardiac output decrease, SVR increase, so that we can perfuse everything. For PCWP, we're going to have an increase in PCWP. Now, once again, PCWP just means that left atrial pressure. Now, let's take a step back. Let's think about it. If I can't get blood pumped out of the heart because I have left ventricular dysfunction, for example, all that blood's going to back up. And since that blood is backing up, I have an increase in pressure of my left atrium, hence the increase in pressure in PCWP, because I can't get the blood out of my heart. Okay? Next is central venous pressure, the CVP. Well, once again, I'm backing up all that blood. The blood cannot be pumped out of the heart, so it backs up all the way into the veins. And in the veins, we're going to have an increase in central venous pressure. Okay? So that increases. And lastly, once again, our organs can't be perfused well enough, so they're not getting enough oxygen. So what are they going to do? They're going to take out all the oxygen that they can out of the blood, and then that's why you get a decrease in venous O2. Okay? So for cardiogenic shock, once over, either caused by an MI, heart failure, valvular dysfunction, anytime that the pump isn't working well enough, you get a drop in CO, cardiac output, an increase in SVR, an increase in PCWP, an increase in CVP, okay, and a drop in SVO2, okay? Next is obstructive shock. And obstructive shock is separated into two sections. It depends on what's being obstructed. And that's key to this. So let's start with a PE, okay, so pulmonary embolism obstruction. With a pulmonary embolism obstruction, the PE, okay, for an emboli, it travels through the right side of the heart into the lungs, and it gets lodged, okay, it gets lodged within the lungs. So everything before it, so all the right-sided heart is going to have increased pressures, and everything after it is going to have decreased pressures, the left side of the heart, right? That makes sense because the obstruction is occurring at the lungs for a pulmonary embolism, a PE. So let's see. Once again, we have a decrease in cardiac output because we can't get blood from the right side of the heart to the left side of the heart. So we have a decrease in cardiac output. What do our sympathetic nervous system do? They increase SVR, okay, in order to get more perfusion. And then our PCWP is dropped. Well, why? Well, the reason behind it is because there's no blood coming to the left side of the heart. And we know that at PCWP is our left atrial pressure. So if there's no blood getting to the left side of the heart because the block is in the lungs, then there's no pressure. So we drop the pressure of the PCWP, okay? And then our central venous pressure is going to be opposite. It's going to be increased because blood is being now filled up in the right side of the heart, and it's going to back up all the way into the venous system because it can't get past the lungs. So it starts at the lungs, and it's going to build up through the heart, the right side of the heart, and it's going to build up through the veins. So that's why our central venous pressure is going to be increased for a PE. Okay? Now, let's talk about cardiac tamponade. For a cardiac tamponade, we're going to have compression of the heart at all angles. Because what did I say cardiac tamponade was? Cardiac tamponade is just fluid surrounding the heart in the pericardial space, right? And so since the heart can't fully relax within the pericardial space, they call this as an obstructive shock, just like how PE is. But the PE is obstructing specifically in the vasculature. This cardiac tamponade is obstructing the whole heart. The whole heart can't relax. So what are we going to see? Once again, since the whole heart can't relax, that means it can't fill from the venous system. And since it can't fill from the venous system, it can't give out any cardiac output. So cardiac output drops. SVR responds normally with an increase. And our PCWP, guess what? We have pressure surrounding the whole entire heart. So we have external pressure. Although there's no blood inside the heart, right? It's very hard to get blood inside the heart. We have pressure squeezing on the heart. And since there's pressure squeezing on the heart at all locations, left atrium, left ventricle, right atrium, right ventricle, we see an increase in PCWP because of that cardiac tamponade squeezing from the outside, okay? And then, as I said, no blood could get into the heart because of the cardiac tamponade. And so we have an increase in central venous pressure, right? Makes sense. So overall for obstructive shock, it just depends on where the obstruction is occurring. For PE, the obstruction is occurring in the lungs. So everything after it is going to have a decrease in pressure, like PCWP is decreased. Everything before it, like central venous pressure, is going to be increased, okay? For cardiac tamponade, right, we have pressure surrounding the heart. So all the chambers are going to have increased pressure because of the blood surrounding and pushing on the heart within the pericardial space. So we have an increase in PCWP. But we also have an increase in central venous pressure because we can't fill the heart. So it's being blocked from downstream, okay? Lastly, this one is the oddball out. This is known as distributive shock. And the way that I think about distributive shock is just our vasodilation shock. This one is complete dilation, okay? And this is their favorite thing to ask. And the causes are sepsis or anaphylaxis. So as you might know for anaphylactic shock, right? So anaphylaxis, we have a crazy vasodilation occurring throughout the whole entire body, okay? And that vasodilatory response is going to help us see what happens with all of those markers that we were talking about before. And distributive shock just talks about a highly distributed issue. So anaphylaxis is throughout the whole entire body. Same with sepsis. Sepsis involves the whole body. So it's completely distributed throughout the whole entire body. So let's begin. And remember, think about it as a complete vasodilatory issue. So massive vasodilation everywhere. Okay. So the first thing, we have massive vasodilation. Well, your first answer might be, oh yeah, cardiac output and SVR. Cardiac output decreases, SVR increases. No, this is the only exception to all shock where cardiac output is increased and SVR is decreased. And the SVR being decreased is very key, right? Why is SVR decreased? The SVR is decreased due to the fact that, why? We have massive vasodilation, okay? Our body has massive vasodilation. So our cardiac output is fine, it's increased, but we have a drop, okay? And SVR, our systemic vascular resistance has decreased because we have vasodilation. Very key to understanding everything. And since we have massive vasodilation, think about everything dilated. PCWP's dropped and central venous pressure has dropped, okay? Because, once again, we're thinking about dilating everything, okay? There's this blood is just flowing through and it really is just going and going and going with massive vasodilation, okay? And the last thing we need to understand is that our venous O2 is actually increased. Our mixed venous O2 is increased. And they like to ask this question. The reason for distributive shock having increased mixed venous O2 saturation is because of this vasodilation. So what occurs is that since we have such large vasodilation occurring, we don't have the ability for O2 to be extracted from the blood vessels as easily as we did before because we have such a large dilation. And since the blood vessels are so dilated, the organs have trouble extracting the O2 out of the blood. Okay? And so that's why once we reach the venous system, the O2 levels are actually increased compared to normal. So not a problem with cardiac output, but a problem with that vasodilatory issue where we can't extract the O2. All right? So this is the only shock, distributive shock is the only shock with decreased SVR and increased cardiac output. Okay? Now, there are other ones that you're probably asking, oh, Nate, what about like CNS injury? Don't think about those. What I've told you today is very, very important. Focus on hypovolemic shock, second to hemorrhage, cardiogenic shock, obstructive shock, both PE and cardiac tamponade, know those differences, and then distributive shock for both sepsis and anaphylaxis, and you will be good.